Hi class, this is our continuation of the lecture for Chapter 12 on motor speech disorders. We left off having just covered the acquired dysarthrias, and those are acquired because of some neurological incident. So things like a cardiovascular accident, some disease process that impacts the neurological system, degenerative diseases such as ALS or Parkinson's, etc. So we think of them more as applied to adults. The developmental dysarthrias are what we're going to cover next. And remember, developmental means that it is present at or shortly after the time of birth. We're also going to be covering some diagnostic pieces with the dysarthrias in this video, and then we'll tackle the therapeutic interventions in our Zoom meeting. So developmental dysarthria present at the time of birth follows a known disturbance to neuromuscular function, such as anoxia at the time of birth. So anoxia being lack of oxygen at the time of birth, or it can be caused by some other damage to the nervous system at the time of birth. So cerebral palsy is one of those, probably the most prevalent that we can think of when we're talking about the dysarthrias. Cerebral palsy is a non-progressive disorder. So in other words, it doesn't get worse. It is what it is. It results from brain damage at the time of birth, at birth, or shortly after birth. And it is often accompanied by dysarthria, or dysarthria is one of the components that we often see with cerebral palsy. In this case, there are two descriptions of types of dysarthrias that come with these infants and then moving into childhood kids with dysarthria. The first is a spastic dysarthria. And this is probably the one that you're most familiar with seeing in children. It is that low muscle tone, but hyper reflexes. It can affect both the upper limbs and lower limbs, or it can affect one or the other. Their speech is generally very slow in rate and distorted in their consonants and vowels. They have the prosody patterns that we would expect because of the impact of low tone, hypernasality, for example. So my friend Autumn, that I mentioned to you in the last video, this was the type of cerebral palsy that she presented with. The second type is dyskinetic dysarthria. This is usually a much more severe form of cerebral palsy when dyskinetic dysarthria comes along. So there's impaired coordination of the muscles, there's involuntary movement of the muscles, including choreas. Now, it's not spelled like the country Korea, it's Chorea. Choreas are sudden, fast, flailing, jerking movements, sort of out of they're involuntary, they're out of the person's control. And it may also be accompanied by atheosis, Atheosis, which is slow, writhing kind of movements. It does typically involve all four limbs, and persons with this type of cerebral palsy have a very hard time producing speech at all. And if it is able to be produced, it's very strained and harsh and very low in pitch. They typically have very abnormally large jaw movements. I like to give you cultural examples or cultural references when I can. There was a great movie, probably came out before most of you were born, called My Left Foot. It was probably the first movie that made Daniel Day-Lewis, the actor, famous. I do believe he won the Academy Award for his portrayal in that movie of an Irish man who has this form of cerebral palsy and was completely nonverbal until thought to also be very developmentally disabled in terms of his intellectual ability and obviously his communication ability, until they discovered that he had some volitional control of his left foot and were able to then give him a means of communicating by using an alternative device to communicate. So that's career relevant movie, but so my left foot. Causes and risk factors for this kind of, we're kind of tying this dysarthria to cerebral palsy specifically. So the causes and risk factors for the damage that may result in this. We know that, again, they are pre, peri, or postnatal damage to the nervous system. So pre meaning during the pregnancy, peri meaning at the time of delivery, and then postnatal being shortly after delivery. So prenatal factors include things like the genetic issues, so blood incompatibility between the mother and the developing fetus. The Rh factor incompatibility can result in damage to the nervous system. Also, a number of different metabolic disturbances. Perinatal factors, so this is at the time of birth, can include head trauma or anoxia, as we said, lack of oxygen. These things happen when there is premature and rapid delivery or respiratory problems at the time of delivery. I know of a case, gosh, this was 37 years ago, a case in the schools that I was working at in my CF year of a young man who, at the time of delivery, the doctor came in and checked mom and said, everything looks fine. You're not going to deliver for a couple hours, at least a couple hours. They had induced her labor. And the doctor left the room, and the mother delivered the baby within minutes, and the baby fell to the floor. So you can imagine the lawsuits that resulted from that, and he was very, very severely impacted by the cerebral palsy that came along with that. So that's kind of what I meant, an example of premature rapid delivery. And then postnatal factors can include things like infections, like meningitis, for example, or brain abscesses, tumors, head injuries, strokes that happen shortly after the time of birth. So moving on to the diagnostic piece for motor speech disorders. Again, we have to look at not only describing the actual physical act of speech, but how it's also impacting this individual's activities and participation in their life. One of the reasons it's important that we, it's all important that we talk about this, but in diagnosing motor speech disorders, we are looking for those signs that help us make a differential diagnosis. And we'll talk about that term. We may have mentioned it before, but we'll talk about it especially in the chapter on assessment. But differential diagnosis just means the process that we go through to help us come on a diagnosis that is separate from other possible diagnoses. So when I see a child in public school, and they don't necessarily, if they're cerebral palsy, I'm going to expect a dysarthria. But if they're not, and they present with, I need to look at the symptom mix that they come to me to help me decide, is this a motor speech disorder or is it a phonological or articulation disorder? I have to make a differential diagnosis in that. So how do we do that? What are our measurement methods? Well, we use perceptual measurements, so our own perception of their speech. We're looking at that level of intelligibility, how well they make themselves understood, in particular to an unfamiliar listener, but we do also ask family members, parents, how well do you understand your child? We ask teachers, how well are you understanding this child? We look at their speech accuracy in production of both speech or speech movement in production of speech and non-speech tasks. So looking at the motor movement. What is the accuracy of placement of the articulators during speech or in non-speech tasks? So I think I described those once before, an oral mechanism exam where we're asking the child to pucker the lips and retract the lips, or lift the tongue up high and reach up high with the tongue or down low, move it from side to side. We're looking at how well they can accurately match those movements. The goal is to determine the impact of this disorder on various aspects of speech. So we're looking at loudness, and we're looking at pitch, and we're looking at breath support, as well as the articulation abilities. Again, this is helping us critically differentiate from the motor speech disorders. It helps us know what we're up against when it comes to planning intervention for this child, and making prognostic statements. So those are perceptual measures. What is our perception? We can also look at acoustic measures. This is looking at a visual representation of the speech sound. It's called a spectrogram. Now, if we're working in the public schools, it is very unlikely that we have access to this technology. So I can tell you that up front. This is not a technology that I have the advantage of being able to use. But if you're working in a hospital setting, in some of the bigger private practice settings, you may very well be able to have access to this kind of technology. Looking at acoustic measures will highlight those abnormalities in speech production that we can't necessarily perceive by our ear or by our eyes by watching the speech production. They provide information about that full range of speech functioning. Again, the loudness, the pitch, the rate of speech, and then the accuracy of phoneme articulation and co-articulation. We also look at the psychological measures. The physiological measures. These involve measurement of the speech motor system for things like muscle strength and muscle endurance, so tone, and the airflow issues. A full assessment. Whenever I say full assessment, please make the assumption that I'm talking about not just speech, but also including language and including voice and including fluency in the meaning of stuttering, so disfluencies in the speech. A full assessment is important when we're doing these assessments to make a differential diagnosis. We do want to know if there are comorbid language issues coming along as part of this child's presentation, but we also do want to rule out the potential that what we're hearing isn't truly a motor speech issue. It may be an expressive language issue, or it may be a hearing issue. Remember, neither of those things cause an oral motor issue, but often our perceptual measures, especially if this is maybe a case we're not as familiar with. Like I said, true motor speech disorders in young children, other than cerebral palsies, are very rare. So if it's something that you have not done assessment with before, it's going to be really important that you, one, do your research, make sure you know what you're looking for and how to look for it correctly, and then you're doing a full assessment to rule things out. Referral for this assessment will typically come from a physician, but again, if we're in the schools, it will come maybe from parent or from teacher. A child with a really significant motor speech disorder very often will come to school already having services. I don't know if we've talked about this before, but by federal law, public schools are required to provide needed services for children beginning at age 3, for the most part, up until the 22nd birthday, but sometimes even for infants. So, for example, the name of the team I work on is called IPAT, the Infant Preschool Assessment Team. Now, there aren't that many infants that we actually get involved with assessment. That's usually the county programs that are doing that. But just so you know, so if a child has pretty significant motor speech disorders that have been identified while they are in preschool, they probably will be coming to school with it's called an IFSP, and will quickly receive IEP services in the schools. So these referrals, especially on the more involved kids, often an SLP is part of that inpatient hospital team, or the outpatient team that would be following the child. So this is obviously the kids more we're talking with. This child has had a developmental dysarthria that came along for the ride with the cerebral palsy, and there's a whole diagnostic team or intervention team that's been following this child from the time of birth. Often an SLP is part of that team. To do a comprehensive motor speech exam. I said this a minute ago, but we'll say it again. The comprehensive exam should include both speech and non-speech tasks. And the reason we do that is to sort out any contribution that language may be making and may be perceived as a motor impairment. Motor speech disorders cannot be explained by a language impairment. we should always include assessment in that World Health Organization third step, the participation in life, right? As well as problems at each level of functioning. So we're looking at body structure, body function, activity, and participation, and then those other contextual factors. So we need to be interviewing parents, or in the case of a much older child or a young adult, interviewing them. How is this impacting your participation in life and your desire to continue that participation or to increase that participation? Assessment needs to include each of the speech systems. So, in the area of respiration, we would be looking at, I'm going to back up for a minute. In the area of respiration, by itself, a respiratory weakness would not result in a motor speech disorder. But when it's paired with weakness in all of the other systems, speech can and probably will be undermined. So the symptoms of impaired respiration in terms of speech would be things like very short phrases in their utterances. They have to stop and take a breath very often. Reduced syllable repetition. Okay, that's a diagnostic task. So I might ask the person to say ba 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 and say it as long as they can until they have to take a breath. We would expect someone to be able to make very many repetitions of that, even in that slower repetition frame. But someone with a weakness in the respiratory system would not be able to get many repetitions out before needing to stop and take a breath. Decreased rate of speech. Again, this is because of the slowness and discoordination of the muscles. Uncontrolled phonation. Sometimes we're hearing voice even when the person is not trying to make voice. Disorders of breath control will impact speech rhythm and loudness and rate. So then we move on to the phonatory system or phonation. We know that the dysarthrias will present with abnormal strength or control of the muscles of the larynx. Also, sometimes the low tone comes with a bit of a different presentation. Obviously, phonation is impacted by issues with the respiratory system as well, but the symptoms we're looking for now in phonation are reduced loudness, the inability to make the voice as loud as you would like, or variations in loudness that seem to be uncontrolled, sudden changes in pitch or reduction in the pitch range, and breathy or harsh vocal quality. All of those tell us there's something going on with movement of the muscles of phonation within the larynx. The resonatory system, the resonation, impairment in the function of the velum, the pharynx, or both, so that velopharyngeal port. We will see decreased range or speed of motion, changes in muscle tone there, abnormal reflexes. People often try to compensate for this with reduced rate of speech, so they're trying to control for that oral nasal airflow, but the result is typically hypernasality. That means too much. Anytime something is hyper, it's too much. Hypo, it's too little. So hypernasality, they're very nasal speech. And then obviously our assessment of the articulation, the articulatory system. Again, articulatory errors can be from weaknesses from any of those other systems, but we need to look for weakness in the oral muscles, so the lips, the tongue, etc. Errors in some dysarthrias will be consistent across contexts because the physiological malfunction is stable, is somewhat consistent. In apraxia and in articulation disorders, apraxia, the articulation disorders are inconsistent across those contexts because they're the result of planning and programming weakness or deficit. So again, I'm going to repeat that. In dysarthria, often the errors are consistent because the physiological system is consistent in its damage. Whereas in apraxia, the errors are inconsistent because they are errors in planning and programming. So that's a huge differential diagnosis piece for us to look at. In the area of prosody, now we have not called this a separate system for speech, but it's an important aspect of speech that helps us characterize a person's speech as natural sounding, not forced or stilted, for example. Prosody involves interaction from all of the speech systems. Prosody is controlled exhalation of air across a series of syllables, so looking at loudness and duration, that's then coordinated with pitch changes, so the phonatory system, and then the articulation system, so shortening of movement relative to syllable duration. I know this is a lot of information, but again, just think of prosody as that rhythm and melody of speech, and you can see how it's impacted by all of the other systems. Examining prosody can help us define, again, the type of impairment, because it can help to determine which systems are most impacted by the disorder. And how we would do this would be to use contrastive language tasks. So I'm just going to show you one example. Contrastive language tasks take a phrase that we then have the person repeat after us with different prosody. So if I said, repeat the phrase, is this new? I didn't really use too much prosody. Is this new? But I want to put prosody in it. Is this new? Is this new? And now I want to change the word order. This is new. You can hear my prosody change across all three of those examples. Persons with impaired prosody will have very difficult time matching prosody in repetition and using prosody sufficiently in their own speech. So, diagnosis. I'm going to remind you again that in the public schools, we do not make a medical diagnosis. It is not that we are not equally as trained as someone working in a private position, because we are. We are all, anyone who holds their C's has passed all of the same competency exams, holds the same licensure. It's just our task in the public school is to look for educational impact. So we don't, as a public school employee, make a diagnostic statement, okay? Just want to clear that up. But, let me tell you, I'm going to get on a soapbox for a second, why I want to clear that up. We hear from parents, we hear from teachers, we even hear from administrators sometimes. Well, we're going to refer this child, or I'm taking my child to a real speech pathologist, one that doesn't work in the schools. And you can imagine how that sort of raises our hackles, because often the public schools do at least an equal, if not better, job of doing these diagnostic pieces. The only thing we don't do is apply a medical diagnosis at the end of that. So it becomes an issue sometimes. So diagnosis. Differentiate. This is going to differentiate a person's disorder from similar other disorders. Remember the term differential diagnosis. Differential diagnosis of a motor speech disorder is based on perceptual findings and clinical judgment. There is not one single test that by itself can provide that differential diagnosis. We have to do a multitude of testing to come to that diagnosis. Dysarthric speech is much more consistent in its error patterns than apraxic speech, and that is a huge piece of that differential diagnosis. Okay, I'm going to stop this video now, and we will continue the rest regarding treatment of speech disorder, motor speech disorders in our Zoom meeting. Okay, bye.